This will be a quick primer on ovarian cancer, which might give you some good background in either your gyn-onc clinic or gyn-onc surgery experiences. The aim of this video is to briefly discuss the current ways by which we could do ovarian cancer screening at this time and the current recommendations. Let's start with a short background first. Ovarian cancer is the fifth leading cause of cancer in women, with 22,280 new cases diagnosed in 2011. It's the leading cause of death of all gyn cancers, and most unfortunately, 65 to 70% of the time it's diagnosed at an advanced stage. 5-year survival rates are pretty bad too. 90% survival at stage 1, which dips down to 33% at stage 3 to 4. Unfortunately, the transition time is unclear between stage 1 and stage 3 and 4. Now, ovarian cancer is one of those unfortunate cancers with few risk factors. 90% of the time it's sporadic and very few presenting symptoms. I've listed here the presenting symptoms, which could include abdominal fullness or distension, abdominal or back pain, decreased energy, and urinary frequency. Now, unfortunately, none of these scream out ovarian cancer. And to make things more challenging, definitive diagnosis requires the surgical excision of the ovary and fallopian tube. And there are no good screening tests for ovarian cancer. Now, given that we don't have any particularly good screening tests, let's look at our toolbox of what we do have. Now, our toolbox of ovarian cancer screening tools would contain the following: CA-125, transvaginal ultrasonography, tumor markers, and proteomics. Let's go through each of these tools in a little bit more detail. CA-125 is what you're most likely familiar with. It's a blood test, so it's minimally invasive, easily repeatable, cheap, and available. It's also not operator dependent, so the results can be reproduced easily. CA-125 is elevated in 80% of patients with advanced stage, but also elevated in 1 to 2% of the normal population. The unfortunate part, which is why it's not ideal, is that it's elevated in less than 50% of stage 1 cancers, which is really the population for which we want to detect ovarian cancer sooner rather than later. And then finally, false positives are found in many non-cancer and cancer diagnoses, as I've listed below. This is probably not worth memorizing, but interesting to note. The next tool we have is transvaginal sonography. This basically means detecting changes in size and architecture of the ovaries. I've pasted a table from DePriest et al., which uses parameters such as cyst wall structure, tumor volume, septum structure, and uses a score of greater than 5 as a predictor for ovarian cancer, with an 89% sensitivity and 70% specificity. Now, I put this down just to kind of give you an example of what we would be looking for if we are to use transvaginal sonography to diagnose ovarian cancer. Unfortunately, transvaginal sonography is still pretty expensive and has operator variance, which would make this less useful than CA-125. In addition, this tool has a high range in positive predictive value, anywhere between 1 and 27%, depending on how high risk the woman was to begin with for developing ovarian cancer. Now, the last two tools in our toolbox are tumor markers and proteomics. As far as tumor markers go, there are over 30 serum markers, all of which are mostly helpful in improving the sensitivity of CA-125. I've listed examples here, but again, probably less useful for you to memorize, unless you're specifically interested in gyn-onc. Now, these tumor markers, if used in conjunction with CA-125, are said to increase sensitivity by 5 to 10%, but will decrease the specificity. Finally, proteomics, or the identification of a distinctive signature or pattern of proteins for ovarian cancer patients, may be used. Once the pattern of proteins or peptides are determined, a bioassay may be developed for each protein that's discovered to help increase the sensitivity and specificity of the detection of cancer, especially when compared to CA-125 alone. Now, this is still in the works, so there's not any particular ones that are used on a regular basis, but it's something to think about. The challenge, of course, herein lies with reproducing the research, since it's pretty expensive to do this work and requires similar quality of chips, handling procedures, and calibration protocols. Now, given that clinical trials come and go, it may be worth doing a quick PubMed or Google search of current ovarian cancer screening trials to see if there are any ongoing ones or ones with new results. Now, if you remember one thing from this talk, it's what are the current recommendations for screening the average risk woman for ovarian cancer? It's done. I've listed all the societies here, which are pretty much the major societies in OB as well as cancer, all of whom have said no screening for average risk women. Now for those with high risk women, and I've listed what encompasses high risk down below, is measurement of serum CA-125 every 6 to 12 months from 30 to 35 years old, as well as transvaginal sonography. They also recommend to remove the tubes and ovaries of those between 35 to 40 years old, or at completion of childbearing, or at the age when ovarian cancer was diagnosed in affected members. Now, unfortunately, there are no studies that show survival benefits even in these high-risk patients, though there is recommendations to screen them. Now for the take-home points. There are currently no recommendations for screening ovarian cancer in average-risk women. Now for high-risk women, the recommendation is transvaginal sonography and serum CA-125 every 6 to 12 months from 30 to 35 years old, plus bilateral salpingo-oophorectomy between 35 to 40 years old. But unfortunately, there are no studies that effectively show the survival benefit, even in high-risk patients. Thanks for listening, and hope you learned a little bit more about ovarian cancer screening and can use this on the wards. Good luck!